practice and workplace culture. So using the person-centered practice framework as a foundation, programs of work Karen leads focus on the quality improvement, the patient safety, and implementing evidence-based practice change, whilst developing a deeper understanding of the influence of leadership on person-centered practice and workplace culture. So Karen's interests focus on the use of the person-centered approaches to support the ongoing development of capacity and capability of the nursing and midwifery workforce. She has extensive skills in coaching, mentoring, and facilitation of learning, and is currently a PhD candidate with her area of study focusing on developing a deeper understanding of the relationship between person-centered practice and the relationship that it has on patient safety outcomes. So welcome, Karen, to this space, and we look forward to hearing your words of wisdom.
Thank you, Barb, and thank you, Susie, for that lovely acknowledgement to country. It's great to be here this afternoon, and thank you for the invite to be on the third masterclass of this wonderful series and collaboration between the two districts. So this afternoon, what I'm hoping to achieve is really to share a journey that I've been on as a Director of Nursing here at Prince of Wales over the last 3 years, but that the experiences I have been over many years, and I've brought those into this role, and how we've really gone about working in person-centered ways to achieve person-centered practice, but most importantly, how does person-centered practice and quality and safety come together? So I hope that you, in everything I share, there's something for you that you can take away and hopefully think through a little bit further with your teams and your context in which you work. And then maybe we can further our network and have further conversations. But this will just be really snippets of the journey that I've been on. And I haven't gone into a lot of detail in a number of the programs of work, but it's just to get you a sense of some of the approaches that I've been taking. So to start us off today, I thought it'd be nice to share with you a care opinion. So at Prince of Wales and Sydney Eye Hospital, we use care opinion as one way our patients and family and the community can give us feedback on our service. So this lovely post, I think, really captures the importance of working with a patient and their family, and their specific needs and preferences. So my family in particular, my relative, would like to personally thank and acknowledge the healthcare professionals from the Wales Hospital in the home team. Dr. Carl, a very efficient, and Jocelyn, community nurse, who recently provided exceptional and effective acute care treatment to my relative within the privacy of their home. Both Dr. Carl and Nurse Jocelyn worked collaboratively as a team to treat my relative for an acute infectious episode, preventing the need for hospital attendance. Their expertise, knowledge, and kind, compassionate manner was greatly appreciated. I felt the care provided was seamless and thorough, whereby my relative responded very well to the treatment and is now fully recovered and back to normal activity. We wish to acknowledge the important exceptional services provided by all the health professionals we dealt with within the Prince of Wales Hospital in the home community healthcare team. This team provides state-of-the-art treatments for patients in the community in the privacy of their own homes, reducing the burden on acute hospital services, which is so important at this present time of the COVID pandemic. In my opinion, this team has the model for success for ensuring wellness in our community and has a unique formula to facilitate sustainable health and well-being, whereby dignity and privacy are maintained. Sincere thanks to Dr. Carl and Nurse Jocelyn for their professionalism, care and kindness in assisting my relative and our family through a difficult time. So I think that really captures the essence of person-centeredness. And I guess I wanted to start our session because I'm sure we've all come from different environments and different contexts and a lot going on this morning, and just wanted to get us into that frame of what we're here to talk about this afternoon. So the Prince of Wales Hospital is a place that's very dear to me. I started here as a new graduate nurse in the early 90s and spent a good 18 years here working in different clinical, education and management roles. And then I headed off to explore further and really develop as a leader, and worked in different LHD, different hospitals, and both at hospital and LHD level to experience that different perspective around how do we develop strategy that will really make a difference at the patient bedside. So it was one of my proudest moments when I returned to Prince of Wales 3 years ago as a Director of Nursing, and it's something that I really, really am proud of. So my vision for quality and safety and culture in healthcare, this is a personal vision, and this is, I think, as a leader, it's really important that we take the time to explore what we're aiming to do in our role, and particularly in our leadership role. So for me, I believe my Director of Nursing role is building and strengthening a culture which focuses on person-centred practice that is safe and effective in environments that support teamwork, learning and improvement. So underpinning my vision, I guess that's been informed by many things, different experiences, different literature, different mentors that I've had over the years. But the things that I've learned is that it really does take courage to lead. And by that, I mean in a positive way, that really sometimes we need to step outside of our comfort zone and do things that may be a little bit different for us. And I guess for me, when I was starting out and exploring person-centered practice and practice development, that was really being courageous and thinking a little bit differently than I had previously done for almost 18 years of my career. So for me, it's important that I find ways to connect leaders meaningfully to person-centered approaches, that I am able to make meaning of the different contexts and environments that our workforce and our patients are receiving and providing care in, that I have good sound understanding of how do we evaluate practice as nurses and midwives, that I create a sense of ownership of the change process within the workforce. And I also am really open to methods and approaches around learning on and from practice. But I guess what is really important is being really aware of self. And I think most of us who have done leadership programs, that's really module 1, where you do that self-exploration around what does leadership mean to you, but more importantly, what are some of the values and beliefs that are important to you that will shape your leadership style and your attributes. So for me, I actually realise now that what is important to me was shaped really early on in my life. And as a young girl, my stepfather would say to me, "Civility costs you nothing, Karen." And then when at high school, my school motto was "Do what is right because it is right." And what those two repetitive sort of statements did to me over those formative years was really reinforced to me how central relationships are and how much I value human-to-human connection, and in particular through a relationship. And so for me, it's about having an open heart and respecting the differences of the people around me. And these are the things that I take into my leadership and into my Director of Nursing role when I'm either developing strategy with my team or working operationally and dealing with the challenges that we face on a daily basis around patient flow and workforce. So of course, it's really important when we're thinking about how do we bring together or develop person-centered practice and focus on the quality and safety of care, that we look at the macro level and look at some of the strategic influences that we have around us. And for me, I've highlighted a few here that are both LHD level strategic plans for the district. Some of them are nursing and midwifery very specific LHD plans from the past. But you can see there's also state influences. So looking at the state health plan and what it's saying about person-centered practice, what it's saying about quality and safety, looking at the Elevating the Human Experience framework that was launched over a year ago by the ministry, and really making sense of, well, what does that mean for us here locally? How do we actually bring these strategic plans and influences into everyday work that we do with staff and with our patients and families? So I just wanted to share that because I think it's really important to have that macro view and take a step back sometimes and look at that before we go down a path, particularly in my role before I launched into what we're going to share today. So I thought it'd be good just to clarify what we're talking about. So person-centered practice. So there's a definition there by McCormick, McCants and Maben, which is back in 2013, but really hasn't changed a lot. And we can see there, it's about establishing and forming and fostering healthful relationships between care providers, service users, patients, families, and anyone significant to them. It's underpinned by the values of respect, self-determination, and it's enabled by our cultures of empowerment that foster continuous approaches to practice development. But for me, it's the statement at the top of the slide. It's about values of respect for personhood, authenticity, shared autonomy, respect, mutuality, therapeutic caring, and healthfulness. For me, that's what person-centered practice is. I will just direct you to some literature here at this point, and it's by some colleagues, Edgar, Wilson, and Moroney, who have written a paper on just sort of clarifying the differences between personhood, person-centered culture, person-centered practice, because these terms are often interchanged, but they actually have really different meanings. So it's a really great reading. It gives you a lot to think about. And it really starts to put an argument forward that how we view personhood, so how our healthcare staff view personhood really starts to impact on the way they deliver care using a person-centered approach. So I think I would just offer that as a reading from today's session, because it certainly started to open up my mind and made me think about, well, what does personhood mean to me, and what's person-centered practice mean to me as well? So quality and safety definitions, I'm sure we're very accustomed to. So patient safety really is about the prevention of harm and how we have systems and processes and a culture that minimises the harm that's experienced due to our care. And then quality is around how we have processes, again, in place, but we're looking at those desired health outcomes and the evidence-based translation into practice. And it's effective and efficient and those type of things as well. So these are often interchanged as well, these definitions. So I think it's important that we think about what they mean. And for me, when 2 years ago, when I started my thinking around a PhD, I started to think, well, what happens when you bring these two things together? And in the very early stages of me exploring the literature and reviewing the literature, I looked at person-centered practice and quality and safety, very broad topic for a literature review. And this was the summary 2 years ago, which really, at that time, there wasn't a lot of literature there that had comprehensively reviewed and evaluated person-centered practice and quality and safety. So I went on to a much deeper review, and I have these references to share in the reference list for you, but there's some really great systematic reviews, umbrella reviews that have looked at extensive number of papers and looking at the impact of person-centered practice on quality and safety. So from my reading of the literature, and I'm currently writing a literature review at the moment as part of my study, it's really obvious that in the literature there is support for person-centered practice as a foundation for achieving high quality healthcare that contributes to better outcomes and experiences of care for patients. A number of the studies have demonstrated that the implementation of person-centered practice can lead to significant improvements in things like patient satisfaction, as well as workforce engagement factors and staff attitudes such as job satisfaction, the level of emotional stress they experience, and general workforce and well-being. And most importantly, a number of the studies have demonstrated the links between person-centered practice and some of the clinical outcomes, such as improved mortality and better adherence to treatment plans. What I was also interested in is that direct link to patient safety. And so there is some evidence available that has evaluated the impact of person-centered practice on very specific safety indicators, such as falls reduction, pressure area reduction. And I would guess the reference I'd refer to here is an umbrella review by Rossiter, Levitt, Jones and Peach, is Australian authors in 2020, who examined the impact of patient-centered care on patient safety. And when they did that with over 250 articles that they reviewed, they actually concluded that little research specifically evaluating the impact of person-centered practice on that whole experience of patient safety across a number of contexts, it doesn't exist. So there is a gap in the literature that needs to have more extensive evaluation and exploration of the relationship, because at the moment it's very, very focused. So it's about an intervention and did it reduce falls, or an intervention and did it change engagement in the treatment plan and sustainability of the treatment plan, or did it change the rate of pressure injuries. So if we're looking at how person-centered practice, but more importantly, person-centered culture impacts on quality and safety, there's a lot of room there to do a lot more research and a lot more evaluation. So I thought I'd share some of the underpinning frameworks that have helped me shape the strategy here at Prince of Wales. So the person-centered practice framework is the first one, and I'm sure many of you are quite familiar with it. This is the most recent version by McCants and McCormack, which has evolved over a 20-year period of different research. You can see there that it's about empowering and engaging people. It's about strengthening governance and accountability. It's about how we evaluate the care experience, how we look at models of care, and how we create those environments for change. And there's different layers to this framework that cut across the macro, meso, and micro levels. And so this framework for me, on a personal note, is really what I use to map some of the work that we're doing here at Prince of Wales to see how is our approaches, or what are the approaches we're going to adopt in this particular program of work. How does that sort of fit from a person-centered perspective? And this is something that I really actively keep working on, and it's quite a visual thing I have in my office where I keep referring to, and particularly useful to talk with when talking to my team. I think that it's important to note that the framework is just a tool for me at the moment as a mapping tool, and then I embed those person-centered processes into the work that we're doing. But we have our ups and downs, and you know, it's that journey that I'm going to share now with its ups and downs, but with the courage and perseverance and having a common purpose and being really clear around values that I believe this framework has helped really work towards our vision. The other reference that I refer to and use quite regularly now is the Venus model. We heard about that in our first masterclass by Kim Manley and Carrie Jackson from 2020. And this is the Venus model of person-centered sustainable transformation. And I initially used this model to take stock of where we were at as a nursing directorate and identify capacity within nursing, particularly within nursing leadership. And this model basically outlines that there's 5 key skills of really transforming a culture towards person-centeredness. And that is, do you have facilitation skills? Do you have improvement skills, leadership skills, culture change skills, and practice development skills? Now, not everyone needs to have all of those skills, but within a workforce and within a team, do we have those skills within our individual team members? And collectively, how do we bring that together for culture transformation? And so that was really important for me. And I guess when I was mapping out the investment in professional development and looking at the past, what I found that there had been a lot of development in these skill areas, and that really what I needed to do was harness that learning, bring those like minds together, and actually collectively look at how we were going to use their strengths and skills in the direction that we wanted to move around person-centered quality and safety. Oops, sorry about that. So the first step was creating space. I guess as a leader, this takes a lot of courage to pause and bring people together to look at, well, what's currently happening now, and really making sense of the context. And so this was something I did in 2019 when I commenced in the Director of Nursing role, where we paused, we looked back, we reflected, and we explored with the leadership teams, focusing on the quality and safety work at that point in time. We had over 100 leaders come into a space prior to COVID, and we're all in a function room And we actually workshopped for the afternoon certain key questions around what was a nursing leader's role in safety culture. We looked at what the attributes of a flourishing workplace were, using the COSI framework there on the screen. We looked at the roles and responsibilities of managers, educators, CNCs in leading quality and safety, and did that role clarification. And the feedback from the workshop was really, really positive. It was about, you know, it's nice to talk about something positive. It's nice to talk about the future, honest, sharp conversations, because we talked about the positives, but we also talked about the current challenges. And some of those challenges were that we needed to repurpose and have a common purpose again. So that was really important feedback. So what we did was really, by looking back at the past, and Prince of Wales had been one of the first hospital to implement essentials of care over 13 years ago, we had to look back at that and say, well, what did we learn? What do we see now in our work, in our wards that represents that framework? And I guess what we saw was remnants of that in some places, and then in other wards where they had completely embraced that approach, and it was a way of being. So there was just a lot of inconsistency. So what we talked through in the workshop and with the leaders was that what they wanted was some standardization and something they could all take to their unit and contextualize, so that they could make meaning for their team, as well as the different types of patients that they provided care for. So that was really how our quality and safety framework came about on the right. And I guess it was something, if you look at it, really, it is the EOC framework around the outside. It's a very generic quality and safety framework. But what we added in here was that central piece in the middle, the culture map, where we wanted to look at 4 key elements of evidence that would give us some feedback on how and the effectiveness of our service and the care that was being provided. So that was added there as a very consistent approach. So that this is just what explains, we asked the teams to take this away and go back to their local teams and spend a period of 8 weeks exploring these 4 key questions in the middle there. So we wanted them to look and work together on, well, what does quality and safety look like in our ward? How have we agreed to work together to achieve our unit vision for quality and safety? What does staff engagement in the work that we're doing here around quality and safety improvement look like? And how are we going to evaluate and report any changes we've made? So that was really important conversations that needed to happen locally, and we gave them the 8-week period so that they could be supported with facilitators from our education unit and work through some of this, so that they were really resetting and developing their quality safety culture framework that was meaningful to them, and that wasn't just a one size fits all type approach. This is where we really contextualized and individualized the approach using the framework. So really important when we're thinking about the person-centered practice framework and working with values and beliefs, that was obviously step 1. So each of the teams went back to values and beliefs and looked at their vision. Many of them had vision statements. Many of them had identified values and beliefs before, but teams have changed. Different people had come in and out of different roles, and it was a good time to just reset that. And as you can see, they all look a little bit different, but they're all meaningful to that team. And that was a really important very first step around what does quality, safety and culture mean to us using our values. Another important factor was looking at engagement. So how do we actually engage with all of our team members around quality and safety, and particularly using person-centered approaches? And I guess that also looked very different. You can see some use strengths, others use more of a above and below the line behaviours method, others developed ways of working, others talked about safety huddles being the place for engagement for them. So again, really important that it's contextualised and is meaningful to that group of staff. But the engagement of staff is actually critical for any improvement work that you're going to do. And we learnt that really early on. And that is really at the heart of practice development, where you can have from the ground up and from top down, and those two approaches come together through an engagement strategy that really has a common purpose. And so that's what we were hoping to achieve. As I said earlier, this was really, really important. What data and evidence is important to our patients, our families, and our staff? And this was the culture map. So each unit was asked to identify the data and evidence that they had available to them already, or they would like to have available to them, or the methods that they would like to have some training and learning about so that they could collect that evidence. So looking at clinical performance, there's some traditional data there around clinical indicators, IMS, QARS, HACs, quality informatics, then patient and staff experience using care opinion for patients and families, real-time patient experience surveys, some storytelling, emotional touch points. We gave them a whole different array of options, and then they actually chose what they'd prefer in their unit. But it was important that the principle was every unit would have at least one method of capturing patient and family experience, one method to capture staff experience, so that all of the data could be presented back to the staff. And then the final piece of the culture map is the care environment. So how does the environment impact on the care we're providing? And we looked and used some 15-step challenge processes. We looked at our work health and safety auditing and some of the safe environment checklists. But that's really, really important. And a really key part of the person-centered practice framework is the care environment. So it was really important to make sure that that was part of data and evidence. In the process, we looked at our vision. Again, through the workshop and through feedback and surveys, we've come away 2 years ago with the vision of transforming person-centered care together, which is really, I think, representative of where we were at as nurses, and I think resonates today, and it certainly is something that we are striving towards here at Prince of Wales. So our agreed framework, just to highlight on the left there, and then there's some fundamental foundations which I'll share with you around our daily processes, which includes huddles, boards, nurse clinical leads, and our auditing program. So to go through our foundations, we really had to look at how we were presenting some of our quality and safety data. So could staff engage with this? Could patients, family, visitors to the ward? And you can see on the left there, there was a lot of different options and different boards, and some of them quite cluttered. But there were some really good gems in there around safety crosses, quality improvement activities, whole range of things. And what we did is we went around and we photographed 41 units and looked at their quality board, and we got all those photos and we worked with our CPIU manager, and we actually put together a pilot board where we felt started to capture data in a different way, where staff and patients and families could visually look at what was happening in the ward at any one particular time or service, and start a conversation about quality and safety. And so the board was piloted and finalised after that feedback in 3 wards. And this is our board now that's in 41 units at Prince of Wales, and also at Sydney Hospital. It's been introduced. There's also boards in our allied health departments and our executive unit as well. But it's about encouraging data-driven conversations. It's about highlighting the priority focus areas through the safety stars and the quality improvement sections. It's around partnering with patients and families around what matters to you. You said, we did, and how we actually act on feedback. And a really important part is celebrating the positive outcomes and successes. And these boards were well acknowledged throughout accreditation most recently, and I think really have really achieved their purpose of starting a conversation around quality and safety. Another foundation has been our Quality and Safety Huddle format. We'd had a huddle process in place for a number of years, but it was about taking stock and looking at different templates and different scripts that were being used and who was attending the huddles. And in that process, we had a principle that there needed to be a huddle 3 times a day, and the scripts were there initially, which everyone agreed to locally what that would look like, but it was focused on identifying risk and action in particular, and sort of what was happening now in the unit that needed to be addressed, and really discussing what matters at that micro level. Another really important part of bringing together quality and safety, as well as person-centered practice, was developing person-centered leaders that are focused on quality and safety. It's a key strategy of ours, and I'm highlighting 3 programs this afternoon, but we do have many more available, both at the district and hospital level. But 3 I wanted to share today is the clinical lead program. So this was work that we partnered with our CPIU manager to develop and evolve. And this is a program that has had over 400 nurses express interest to be a part of. And it really is around clinical leads in every unit, covering 9 focus areas now, which we've added end-of-life care as well. But as you can see, we have falls prevention, invasive devices, infection control, delirium, deteriorating patient, pressure injury, medication safety, wellbeing, and end-of-life care. And so nurses were asked to express interest if they wanted to be a part of the clinical lead program and be that clinical lead of that particular clinical practice area for their unit. Alongside of that, we had a group of clinical experts, particularly our clinical nurse consultants and our educators from our education unit, develop a curriculum for each of the clinical practice areas. And those groups meet regularly to actually go through the curriculum, go through important audits for their clinical practice area, go through policy change or business rule change, go through if there's been some evidence in the literature that's shifted or a new education approach. These are our clinical champions out there at the micro level, that when you've got so many people engaged in a program like this, this is where we can start to get some improvement change and practice change. And these are a really critical group for us. As I said before, there's always ups and downs, and this is one of the programs that has been impacted by COVID, because we obviously haven't been able to meet face-to-face and have had to go to some virtual sessions, which is a little bit more tricky for clinical staff to get access to computers and things. But certainly this is our focus for 2022, getting through the curriculum and really supporting that number of nurses out there as clinical leads. The other program is the Emerging NUM program, really important 12-month program for emerging NUMs. But as you can see with the workshop program, we spend a lot of time exploring what person-centered leadership means, as well as workplace culture, quality and safety foundations, and risk management. And so that's just bringing that together in that program for our next generation of managers to experience how person-centered leadership can impact on the quality and safety of care and what their role is and how they influence. So a really important part of that program. Our program has been very successful with its evaluation. We're in our 3rd year at the moment, but it's proven to increase knowledge and confidence of the participants. A lot of our staff have now acted in nursing unit manager roles, and so they're influencing and impacting on the leadership of units. But also I thought I'd highlight the change in their understanding around person-centered attributes. So pre-program, they were sitting around 33%, and 12 months later, at the end of the program, they rated themselves at 100% understanding around what the person-centered attributes were of a leader, which is a really nice indicator around the program as well. And our final program around person-centered leadership is the CNS program, which is something that I wanted to do in 2019, where we brought together the existing CNSs. We had over 80 come into a space and reflect on the CNS1 role, because I see them as a really critical role in the development of clinical practice and practice improvement. And so I wanted to understand from them what their development needs were. So we had the focus groups and the forum and a survey that they could access as well. And they said a lot of feedback came back from the group. It was so great to hear from that particular part of the workforce, which I think is invaluable around quality and safety. But they started to identify what their learning needs were, which was fantastic for our education team to start thinking about, well, what could we offer here? Again, I think through the feedback we received from this group, there was a thread and a theme of quality and safety, and really being a clinical leader of projects and wanting to participate in quality and safety activities in their unit, but wanting some more skill development around it. So that was a really good indicator for us around the direction we should take. And so we have the clinical nurse specialist professional development workshops commence in 2020, and they're again in 2022. But there are topics there that is really about developing person-centered leaders that have at first and foremost quality and safety in front of mind. So we look at facilitation as a key skill for leading practice improvement. We look at developing themselves as leaders, as I've mentioned previously, clinical teaching at point of care, clinical supervision, and how they could move into project management and research skills as well. So again, this program is another really positive program that we have to support our journey and our staff. Another foundation in 2020 was to do a baseline measure of our culture using the Safety Attitudes Questionnaire, which is now LHD wide and has recently just been implemented across all sites. But in 2020, we did the survey here at Prince of Wales to really check in on the 6 domains of the survey around safety climate, teamwork climate, job satisfaction, stress recognition, perceptions of management, and working conditions. And it was really important for us to get that measure because we were quite a new executive. We had all just recently come into post. So the general manager, myself, and the director of clinical services for medicine. And I think this was a great start for us to start working together as an executive and, you know, being courageous to put that survey out to all staff, all disciplines, all units, and get some feedback. And really well received. We had over 30% respond, which may not seem much, but it was over 1,500 staff respond. So our results, I just thought I'd share the questions and the colour. It's a traffic light system, so green, orange and red system, very visual, very easy for staff to get their feedback. That's a hospital level result, which we were really pleased with to see a lot of that green, but also it generated conversations as an executive around, well, what does some of this orange and red mean? How can we change things? And we started to change the way we communicate in our staff forums. We've made a few subtle changes based on this feedback, and we're hoping that the next round of results will continue those discussions together. But what the SAQ does is it's really working at the macro level, if you think about the person-centered practice framework and that strategic framework level, the strategic leadership level, but it's actually used to inform the micro. So 54 teams received their individual results for their team, and those results were facilitated and co-facilitated with the team. They action planned, and we had really specific actions related to their data that would make a difference around those 6 domains. They often just chose 1 or 2 of those domains to work on, and that's enough. We didn't expect action plans pages long. I think this really has to be purposeful and really meaningful to that team. And so that data, again, is another set of evidence that teams have access to, and it really is the staff experience around what their experience of safety climate is at that point in time. So another really important factor. So COVID came along and we all had to adapt, and I don't want to dwell on that, but obviously we had to really pivot and take stock and start changing the approaches we had to really support and ensure the safety of our staff and patients. And I guess through that, what I saw was that the work continued, which I'll share with you now. So in 2020, we had a little window of opportunity between surges, and we thought we'll get the 41 teams together to present where they're at. And I guess what happened over the course of 3 afternoons was the staff and the leadership teams presented their local data, their improvement ideas, what were some of their achievements in the last 12 months, and then what were going to be their top 3 clinical priorities for 2021. And I guess that created a sense of achievement because we had worked in very different ways in 2020 due to COVID, but really the focus remained on clinical patient safety and quality. And that was really, really reassuring that the framework doesn't, if we're in the middle of a pandemic, we can back off on some things, but really at the heart of it was the patient safety focus. And that was, I think, really reassuring to us. Equally, there were some themes around person-centred care and how through isolation, PPE, can we do things differently? And those conversations, I guess, were really person-centred. And I was in many where I heard a lot of the nursing leaders advocate for really positive approaches to providing care to those patients who were isolated or who were end of life and experiencing COVID, and how we could bring their family and them together in ways that really addressed their needs. So really positive. And then we went into a phase of evaluation in between as well. So we looked at the huddles at the time in 2021 and what was being discussed in those, which was an important taking stock opportunity. We did emotional touch points with the staff groups, and I guess some of the key words there around confident, supported, feel satisfied by the huddles. It creates teamwork and positivity, and the safety culture was feeling valued and a sense of certainty. And so those huddles really started to achieve their purpose, which we'd set out 2 years before. Equally with the Quality and Safety Board, we evaluated that. So what does this board really mean after a year? And I guess the important thing around some of the staff perception was that monitoring safety data with the board leads to change. I think I might just, so the key learnings we had was processes that I've highlighted today as the foundations enable person-centeredness. The staff of our use standardisation with a sense of certainty and a language that they can share around quality and safety, but with the opportunity to have the flexibility for contextualising it for them and the different teams and patient cohorts that they provide care for. And it's really important to create space for quality conversations within teams and across the organisation. I just wanted to highlight that wellbeing is a really important part of quality and safety. So we have a Prince of Wales Sydney Eye wellbeing plan that really looks at the different layers of individual, team, community and future, because we appreciate that really for our staff to provide safe and quality care, we need to look after them and ensure their wellness and their wellbeing. And we have a number of different opportunities available in our environments for that to occur. It certainly is 100% supported by all members of the executive. We've got virtual offerings for wellbeing as well. I also wanted to highlight that it's also about reshaping your education approaches. So this is a very new initiative where we have developed a curriculum for a session that's multidisciplinary around delivering comprehensive person-centered care in response to Standard 5. And again, I don't have, I've only got pilot evaluation data, but this is now in a hospital-wide rollout at Sydney Eye and Prince of Wales. So really looking forward around how we've embedded person-centered approaches into education as well. And finally, research. I guess that's sort of the end point where we've done quality improvement, that now we're moving into research approaches as well. So we have Sea Change, which is focused on invasive devices and using bundles to map the management of a number of our invasive devices as part of our HAI strategy. We've had Accelerate, which is looking at nursing physical assessment and clinical handover. Most recently, I wanted to highlight the PIPIN study, which is a collaboration with Dr. Jenny Sim, where we looked at pressure injury prevention and practice improvements in nursing. And we used a realist evaluation framework, mixed methods, which really looked at nursing knowledge of pressure injury prevention and PDSA cycles over six cycles of an implementation of change, and really promising results. At the moment, we're in analysis of the data, but we have in the PIPIN wards, the 10 PIPIN wards, we have seen a reduction in point prevalence of our hospital-acquired pressure injuries quite significantly compared to the rest of the hospital. So this program of work and study is now being rolled out in ICU, but it's the approach we took where it is about that local ownership of change. The teams shape the PDSA cycle and then evaluate it So that's been a really important study for us. And our harm score 1 and 2 pressure injury rate is certainly on the downward trend, which is a really important indicator around harm. And so to finish, I thought I'd leave with a little statement here around courage, because I think it's something we all need to think about at times in our roles. So with courage, you will dare to take risks, have the strength to be compassionate, the wisdom to be humble, and it's also the foundation of integrity. So thank you. I'll hand back to Susie.
So, thank you, Karen. I just like taking a pause just to take it. It was such a wonderful journey that you've shared there. That really seeing that. What stood out that in that approach that you said that you take, that every unit is different, and working with that understanding and how you engage, your engagement strategy was just amazing. So we've opened it up. We've got you all on mute, so please feel free to unmute yourself. If we could just have if anybody else got any questions. We've just gone over time, but feel free to comment anything in the chat box or any questions. There's a few having to jump off. How can we have access? Do you mean the recording of
to the first masterclass?
Yeah. So just to make you all aware, we've actually uploaded them onto the South Eastern Sydney Local Health District YouTube. And if you Google that YouTube and go into South Eastern Sydney, you'll see the Masterclass series. We've got number 1 and 2 on, and this third one will get uploaded. And we've actually got them into a playlist on there, so you can share them. Yeah.
Karen, we've got an interesting question from Joe Harris, and I think it's, it's very topical, but have you managed to engage your medical teams in your initiatives? I think this is a really important piece.
Question.
Yep, so we have in some of the quality and safety work that we think about sea change. That's a multidisciplinary approach that I engage the JMOs, Innovation Committee, the JMO workforce, and the medical workforce teaching unit, and the registrars, because as nurses and doctors, we all influence the care and management of invasive devices. So very purposefully have engaged and collaborated with that group. With our Safety Attitudes Questionnaire, that's for everybody. It's not discipline specific. And with our framework and our work, we started with nursing, but some of the plan is, and for our units that work traditionally in a multidisciplinary framework, they've been using it in that way to engage their allied health and some of their medical staff. A little bit more tricky with the medical staff because they rotate. But interestingly, some of the Safety Attitudes Questionnaire work, when we gave back the multidisciplinary booklets, the JMOs, the nursing staff and the allied health staff sat together and developed the actions. And some of it was about medical orientation being more person-centred and individualised and more informative. So the team made some changes. So it is about, my hope is that we can work everything we do in a multidisciplinary fashion. But I think I've learned to take small steps. And really small wins start to show how we can do it. The person-centered practice education, for example, is for all disciplines, and we've opened that up to JMOs on the wards, allied health and nurses, and we want them to be in the same space and have that teaching and education together. So yeah, certainly something that I 100% support.
Yeah. So inspiring, Karen. Lots of thank yous.
No, it's my pleasure. And as I say, it was a bit of a cook's tour, but just wanted to give you a taste of the journey. And it is a journey. It's 3 years in the making, and we've got another many years ahead of us. So
yeah. And it was a big journey, but it was easy to follow, and it was you could see the foundations, the engagement, the programs, and we know that where you are. If anybody did have any questions, you can come through us at the district, or I'm sure Karen would be happily directly to you, wouldn't you, Karen?
Yeah, and I've got an amazing team around me, and I would have to acknowledge Ethna Cannon, Mary Mulcahy, Ben Newland, and many others. All of our nursing education and workforce unit educators who have been part of the facilitation team, they're all part of this. So any one of our senior leaders could talk to you as well about their role in this work.
Yeah. Okay.
Hi, Karen, it's Helen McCarthy here. Thank you for your presentation. That's absolutely wonderful. I remember coming over to Prince of Wales before COVID and meeting with you, and you were explaining this model at the time, and you'd made a start on it, and it's just been amazing to see your journey. I also have to applaud you for continuing and using the breaks that we had during the last 2 years of COVID and continuing the work there. Did you find that problematic, sort of picking up after the staff were sort of tired and quite exhausted, and then going off and then bringing them back again? How did you cope with that?
Yeah, I think, Helen, that's a really good point, because timing is everything. And it's about reading that and really reading the staff and listening and pulling back when you need to. And then really some of it they approached me about and wanted to explore it. So particularly some of the patient safety concerns they had through the pandemic, they wanted to revisit that and brought that up. But we went back to our data. So just sharing really simple data, particularly our HAC data at the time. So when we looked at our infection rate and our pressure injury rate, it was problematic. At the moment now we're looking at our falls and delirium, and that's directly related, some of it, to COVID and some of the isolation and things that are changing in the wards. So it was just keeping it really simple at the time, but then also having the spaces for staff to talk. And there was a period of time between surges where we did just focus on wellbeing.
Yeah, thank you. It's great work.
It is. There's lots more thank yous there. So we will be, like I say, uploading this onto YouTube, and we'll be sharing it with Illawarra also, so they got access to the masterclass. So thanks again, Karen.
No problem. Thanks, Susie.
And
Thank you.
Close there.
Good afternoon.
Yeah.
Thank you.
Thank you, everybody.